A very good afternoon. My name is Sanya Nishtar, and I have the privilege of chairing the fourth session of this amazing convening, which is dedicated to commemorate the launch of the GBD 2010. And let me begin by congratulating Chris for the amazing piece of work that he has put in the public domain. Rifat Atun rightly says that it is a global public good, and from the conversations that we've had around the table today, I'm sure you will gather that this is not just about descriptive epidemiology. This piece of work is certainly going to catalyze some very important set of public policy changes with regard to the management of data systems in the developing countries in particular. I'd also like to congratulate the Lancet and Richard Horton in particular for giving this work the due visibility and prominence that it indeed deserves. Today's session, this particular fourth session of the convening, is going to be focused on risks. So we've moved from deaths and life and disability, and now we're going to focus on risks. And this session is going to be particularly important because intervening in the space of risks is where the potential of gain is the maximum. And as you will see, as we come towards the end of this session, that the potential of change is both in the area of health as well as outside of the space of health, as well as in terms of the individuals and how they take charge of their life. The format of this session is quite similar to the previous sessions. We're going to have an index presentation followed by a panel discussion. And our presenter this afternoon is Stephen Lim, who is Associate Professor of Global Health at the Institute of Health Metrics and Evaluation. He has a broad-based career. He's served in public sector ministries of health. He's worked in the World Health Organization. He's an academic. His core area of expertise, amongst many others, is monitoring and evaluation and impact assessments of large-scale interventions. So, Stephen, the floor is yours for the next 20 minutes.
Thank you, Chair. I'm very humbled today to be presenting the GBD 2010 comparative risk assessment work on behalf of many co-authors. And I'm also extremely grateful for all the countless hours that those co-authors have put into this effort. The attribution of disease burden to various risks is an important complement to the burden of disease that has been presented so far today. It helps to inform disease and injury prevention debates by providing a different accounting of health loss that might not be evident through a disease-by-disease analysis. Since the last global comparative assessment of risk burden, the comparative risk assessment for the year 2000, a number of topic-specific analyses have been published, including the Lancet Nutrition series, and more recently a study looking at the burden attributable to physical inactivity. Now, while each of these studies are very important in their own right, each of them use different methods and data, which means that we can't strictly compare the results from one study with results from another. And the GBD 2010 comparative risk assessment work represents really the first complete and comparable update since the first comparative risk assessment for the year 2000. It includes a number of new risks as well as major revisions of existing risks. Now, the basic approach for the CRA work is to compute the proportion of deaths or disease burden by comparing the current exposure distribution for a risk against a counterfactual exposure distribution, holding all other factors unchanged. In the GBD 2010, we've computed attributable burden for 67 risk factors and clusters of risk factors, similar to the burden of disease analysis for 20 age groups, both sexes, importantly for the first time at the country level and then over time. I'll be focusing results today on results by 21 regions and for 1990 and 2010. The 67 risk factors and risk factor clusters include risks around unimproved water and sanitation, air pollution, including both household and ambient sources, selected other environmental risks, a cluster of child and maternal undernutrition risks, tobacco smoking and secondhand smoke, alcohol use, as well as other addictive drug use, a cluster of physiological risks ranging from blood pressure to low bone mineral density, as well as a couple of sexual abuse and violence risk factors. Now, in GBD 2010, we've also included a large cluster of dietary risk factors and physical inactivity, compared to the original CRIA, which included just fruit and vegetables combined. We now include 14 different dietary risk factors. And as was mentioned in the discussion in the last session, we also include a range of occupational risk factors, including exposures to a range of carcinogens. Now, there are 5 broad steps involved in computing the burden attributable to different risk factors. I'll provide a little bit more detail in subsequent slides. The first step, of course, is to choose the risk outcome pairs that are to be included in the analysis. And my next slide will outline the various criteria we've used to inform the choice of those risk outcome pairs. The second step is to estimate exposure distributions for each of those risk factors, along with the effect sizes for each of the risk outcome pairs to be included. Typically, this is the relative risk per unit of exposure. The fourth step is to choose a counterfactual exposure distribution to assess the burden attributable to that risk factor. And in the GBD 2010, we used the theoretical minimum risk exposure distribution. And of course, the last step in the process is to compute attributable burden. Typically, this was done by estimating the population attributable fraction or population impact fraction, which is then multiplied by the corresponding cause-specific deaths or DALYs produced out of the burden of disease analysis. Importantly, we reflect uncertainty due to a number of sources, the exposure distributions, the estimates of cause effect sizes, as well as the underlying burden expressed as cause-specific deaths or DALYs. In terms of choosing risk outcome pairs to include, we've used 4 criteria to guide this choice. The likely importance of the risk factor to disease burden or policy, the availability of data and methods to measure exposure distributions, evidence around the causal effects, and we have used a criteria of convincing or probable evidence to guide the choice of risks to be included. Importantly, we also require evidence to estimate outcome-specific effect sizes. So in other words, effect sizes that are based on all-cause mortality are not sufficient for inclusion here. Fourth, given that this is a global analysis across a number of countries, we also require evidence to support generalizability of those effect sizes outside of the populations in which they've been studied. As one example, for intimate partner violence and HIV, we have a single longitudinal study from South Africa and quite a bit of uncertainty about generalizability of those effects. So that particular risk outcome paired was excluded as one example of outcome pairs excluded. Now, throughout the CRA work, there have been a whole range of methodological innovations compared to past efforts. I'll use an example produced by the expert group on ambient particulate matter pollution. The map here shows the availability of ground-based sensors for measuring particulate matter exposure, expressed as the concentration of particulate matter smaller than 2.5 microns. Each of the points here color-coded according to the level of PM2.5 exposure. Now, what's obvious here is that the geographical availability of data is extremely limited for a number of regions and is largely confined to urban areas. As a result, the previous CRA work estimated attributable burden just for medium and large cities. Now, in the GBD 2010 work, we've been able to estimate exposure for all populations globally, leveraging two complementary sources that allow estimation of PM2.5 levels in ambient air. The first, satellite-based exposures of aerosol optical depth, a measure of light extinction of aerosols. When adjusted for humidity, this provides a good estimate of PM2.5. The second source are chemical transport models which simulate particulate matter. Now, both of these sources allow very high resolution estimates to be estimated. So for GBD 2010, these are actually at approximately a 10 square kilometer grid level. We then calibrate them against the data from the ground-based sensors, which allows us to produce estimates of exposure as shown in this map. Clearly, very high levels of exposure in desert areas in particular, as well as high exposure levels in the urban areas in China. In terms of risk outcome effect sizes, we relied on recent systematic reviews and meta-analyses. Where these were not available, we conducted new analyses. Some of these include water and sanitation, building upon existing reviews of both intervention studies as well as quasi-experimental studies. The findings from this updated meta-analysis show significant effects for unimproved water and unimproved sanitation compared to improved water and sanitation, respectively. However, we did not find substantially greater effects for household water connections or water quality. The latter has also been seen in other previous meta-analyses. For air pollution, to inform the risk association across the full range of PM2.5 exposure, we've integrated data from a range of studies relating PM2.5 to disease effects from different sources, including ambient air pollution, household air pollution, secondhand smoke, and then also active smoking. A number of new meta-analyses around dietary risk factors, for example, updating earlier work on seafood omega-3s to include the more recent intervention trials. Now, one more important note around risk outcome effect sizes is there is some concern around the effect sizes for single dietary risk factors. Largely because of the correlation structure that's present for dietary risk factors. Individuals who consume more fruits are also likely to consume more vegetables, less red meat, and so on. So as part of the GBD work, we also examined the validity of these single risk factor effect sizes by looking at how well they line up with dietary pattern studies. So these look at overall good or bad diets, such as the Mediterranean diet, as well as randomized controlled feeding studies. And so these are typically over short time periods and examine effects on intermediate outcomes such as cholesterol or systolic blood pressure. Now, both these additional analyses suggest that none of the single dietary risk factor effect sizes appeared to be exaggerated due to that correlation structure. As part of the CRA work, with the exception of physiological risks, as well as air pollution, for which there are complicated interactions between the single risk factors, we have approximated the joint effects for risk factor clusters, assuming independence between the various risk factors. Of the remaining risk factors, noting, of course, that physiological risks and air pollution are likely to have a large attributable burden, The largest cluster was for diet and physical activity, accounting for around 1/10 of global DALYs in 2010, as shown in this tree map. What each of the darker shaded areas show is the attributable burden to this particular cluster for each of the causes. What this also emphasizes is that risks and clusters of risk factors may affect multiple underlying causes. In this case, also other cardiovascular diseases and a range of cancers, diabetes, and then also chronic kidney disease. Now, if we turn our attention to the 43 individual risk factors included in the ranking list for the risk analysis, we can see that high blood pressure was the leading risk factor in 2010 in terms of global disability-adjusted life years, followed by tobacco smoking, including secondhand smoke, and then alcohol use. Now, each of these bars are color-coded according to the underlying disease and injury outcome that's attributable to the risk. So, for example, high blood pressure is largely mediated through cardiovascular and circulatory diseases, whereas alcohol use has more diverse effects across cardiovascular diseases, other non-communicable diseases, injuries, and communicable diseases such as tuberculosis. Now, the leading 20 risk factors, a number of these, as you can see, primarily affect non-communicable disease outcomes. These include high body mass index, high fasting plasma glucose, high total cholesterol, as well as a range of dietary risk factors, including diets low in fruit and high in sodium. Household air pollution and ambient air pollution, in contrast, affect both communicable and non-communicable diseases and are ranked 4th and 9th respectively. The leading communicable disease risk factor is childhood underweight in 2010, ranked 8th here and responsible for more than 3% of total health burden, iron deficiency and suboptimal breastfeeding accounting for more than 2% of total health burden. Now, as Chris pointed out earlier, those types of graphs tend to focus on the point estimates. If we examine the uncertainty around risk factor attributable burden, we can see that the 3 leading risk factors are relatively clear. However, there's considerable overlap across many of the other risk factors, particularly large uncertainty for micronutrient deficiencies as well as dietary risk factors. Now, the focus of my presentation today is very much on the burden expressed in disability-adjusted life years. But I also want to give people a sense of how that relates to the health burden in terms of attributable deaths. This figure shows DALYs attributable on the y-axis against deaths attributable on the x-axis for the top 25 risk factors. As you would expect for physiological risk factors shown here in blue and dietary risk factors shown here in gray, the fraction of deaths attributable for those risk factor clusters is much higher than the fraction of DALYs attributable, whereas for air pollution with effects on both children and adults the difference is less comparing deaths attributable and DALYs attributable. And then for childhood underweight, suboptimal breastfeeding, larger DALYs attributable for those risk factors than in terms of attributable deaths. Now, the picture in 2010 that I showed you reflects a dramatic epidemiological transition since 1990. So in 1990, the leading risk factor was childhood underweight, accounting for around 8% of total health burden. By 2010, it was the 8th ranked risk factor. As you can see by the various dotted lines going down, a number of other primarily communicable disease risk factors have also declined in both absolute and relative ranked terms, such as breastfeeding, sanitation, water, as well as micronutrient deficiencies. In contrast, the solid lines largely represent non-communicable disease risk factors. The two of the most notable ones are high body mass index, which increased by more than 80% between 1990 and 2010, and high fasting plasma glucose, which increased by more than 50% over that same time period. Now, the global results also naturally mask substantial variation across regions, as shown in this heat map. Risks arose ranked by the global ranks, so for high blood pressure down to occupational risk factors for injuries. Regions are ranked by the mean age at death, a marker of the epidemiological transition. From high-income Asia-Pacific through to Western Sub-Saharan Africa. I'll point out here a number of key patterns. So for high blood pressure and tobacco smoking, you can see that those two risk factors are consistently ranked in the top 5 or 6, with the exception of Sub-Saharan Africa. Even in these regions, these two risks are ranked in the top 10. High body mass index is now the leading risk factor in both Australasia and southern Latin America. Importantly, in the 3 sub-Saharan African regions, Eastern, Central, and Western, childhood underweight, household air pollution, and suboptimal breastfeeding remain the 3 leading risk factors in this region. Notably in South Asia, childhood underweight, despite declines, remains the 4th leading risk factor, and household air pollution remains a key risk factor in East, Southeast Asia, as well as South Asia. The risk with perhaps the most diverse pattern over region is ambient air pollution, ranked highly in East Asia, North Africa and the Middle East, South Asia, as well as Western Sub-Saharan Africa. Let me just skip over this next slide in the interest of time, because it certainly represents similar results to what I just showed. Now, in terms of additional key findings, there have been a number of important revisions compared to previous risk assessments. We find a lower attributable burden for unsafe water and sanitation, as well as micronutrient deficiencies. These represent a number of mechanisms. The downward revisions in child mortality, which were shown earlier today, changes in cause-specific mortality, but also importantly, revisions in the effect sizes, which represent more recent evidence. In contrast, we see a larger attributable burden for both household and ambient particulate matter pollution. For household air pollution, this represents the addition of ischemic heart disease and stroke as outcomes attributable to that risk. And as I noted earlier, for ambient air pollution, we have also now included a full computation of exposure for all populations and an approach that captures the very high levels of particulate matter exposure in East Asia. Now, a recent study on attributable burden for physical inactivity estimated 5.3 million deaths attributable to that risk. And one of the key messages that came out of that study was that physical inactivity had a similar health burden to tobacco smoking. Now, in contrast, in our analysis, we estimate around 3.3 million deaths attributable to physical inactivity and low physical activity, around half of what we attribute to tobacco smoking when we exclude secondhand smoke. This particular case, I think, highlights the importance of comparative analyses of risk factor attributable burden that use the same methods and underlying data. Now, a study of this scope, of course, is not without its limitations, and many of the ones that I've listed here echo the theme throughout the day, which relates to data availability, including that for measuring exposure distributions. Now, importantly, it's not just the amount of data that's available for measuring exposures, but the quality of those measurements. So for some risk factors, we have more direct measures of risk than for other risk factors. For example, for exposure to particulate matter from household sources, we use household use of solid fuel as a proxy for risk exposure, whereas for risks such as blood pressure, we have more direct biological measurements. So I think that underscores the need for, I think, future research, better data collection around markers of exposure related to major risks. Now, for risk factors, particularly those without intervention studies available, there does remain the potential for residual confounding. In some cases, we certainly would not be able to do intervention studies. Now, this issue of residual confounding is likely to be most relevant to risks which are newer and have a smaller body of evidence, given the observations that the pooled effect of risks and interventions tends to trend towards the null over time. Now, with the exception of some risks, such as metabolic risks, which have been studied in diverse populations, we also still have considerable uncertainty about the generalizability of those effect sizes. Fourth, given the series of criteria we've used for risk outcomes, we have excluded a number of risk outcome pairs that have been included in past CRA assessments, most notably unsafe sex, for which there really is insufficient data around exposures. And related to that, a few risks for the major communicable diseases, HIV, TB, and malaria. And finally, as noted, we have approximated the joint effects by assuming that there's no interaction between each of the individual risk factors. In summary, our reassessment of risk factor burden as part of the GBD 2010 really highlights the dramatic shift away from communicable disease risks in children towards non-communicable disease risks in adults. Particularly noteworthy, of course, is the global rise in the burden attributable to high body mass index and glucose. And this very much emphasizes research priorities given the absence of effective population-based interventions for these risks. The inclusion of a wider array of dietary risk factors provides us with a more nuanced understanding of the role of diet in preventing chronic disease, moving beyond the traditional message of reducing saturated fat intake. And as we've seen, the major revisions in the quantification of burden for micronutrient deficiencies, but particularly household and ambient air pollution, has critical policy implications. Lastly, I think what's evident in this regional analysis, and will become even more pronounced as we look at country-level results, is the large variation in risk factor attributable burden. And notably, of course, the leading risks in much of sub-Saharan Africa continue to be those associated with poverty and those that primarily affect children. Thank you very much.
Thank you, Stephen, for a very succinct overview of a very complicated subject.